Hey, what's up, everybody? This is Kevin for This Emergency Life, and today I just wanted to review a quick case with you guys. So, I want you to imagine that you're working your usual emergency department shift. You're just minding your own business. You're trying to get through the last few hours of your night shift when you get a call from EMS on the notification line saying that they're bringing in a 28-year-old male who is complaining of severe respiratory distress after ingesting something called Iron Horse. They say they are currently ventilating this patient and they're going to be in your emergency department in the next 5 minutes. So, aside from this being a major drag because you want to get through the last few minutes of your night shift without any major drama, you are going to prep your team, prep your equipment. So, this sounds like a resuscitative case. You're going to get everyone that you need to the bedside, respiratory, your providers, your nursing staff, and you're going to prepare for airway interventions like intubation, get your cardiac monitoring ready, and vascular access. So they actually show up a little bit early and they arrive in your emergency department. And the first thing you notice is this patient looks obviously very blue. They're being ventilated by BVM. EMS was able to start a intravenous line, and you're just moving this patient over and you're just about to ask about this substance, Iron Horse, that they ingested one more time. And the patient goes, as soon as you get them onto the monitor, you notice they go into a Brady asystolic arrest. So you basically start resuscitative efforts. Someone's jumping on chest compressions. Respiratory therapy takes over and does bag valve mask ventilations. They're preparing for intubation. The doc there orders 1 milligram of epinephrine. We do that. Intubation goes smoothly. They are now ventilating through an ET tube, and we do basically 1 round of CPR, a 2-minute cycle, and we do a reassessment, and this patient has returned to spontaneous circulation. So that is awesome. So they have ROSC. Their new vital signs are 164/78. Despite being ventilated at about 20, you notice that they're breathing over the tube ventilations at about 38. They do have a nice strong radial pulse. Heart rate is coming up. It's mid-50s and on its way up, sinus rhythm. And the pulse ox right now is 85. So that's a little curious that it's only 85, but they're just post-arrest. So before we all give each other a bunch of high fives for saving this guy's life, we have to start thinking about what led us here. So what is your differential diagnosis for this patient at this point? So while you think about that, we're getting other things like we have to put more lines in, we're drawing labs. Someone who's drawing the labs actually noticed that the blood looks really dark. And you just kind of take notice of that and make a mental note of that. You guys are actually have a really good turnaround time for your labs, and you notice that that most significantly on like his CBC and BMP, that you notice most significantly that he has a lactate or a lactic acid of 18.9 and a serum bicarb level of only 10. So you have a very serious acidosis. Everything else looked okay at the moment. You have respiratory therapy there, and they are drawing an ABG. And when that ABG comes back, it shows that this patient has a profound metabolic acidosis. So the pH is only 6.9, and PO2 is really low. We're under 30%. So profound hypoxemia as well. And we have like a borderline PCO2. On this ABG that comes back, you see a value there that you're not really used to seeing all that often. And that would be the met hemoglobin. And if you don't know what that is, that's fine because we can go over it. But this met hemoglobin level is about 40%. So what does this all mean? What kind of patient are we talking about here? What led to this patient's respiratory distress, this profound acidemia, still present cyanosis that's going on even now, even despite being ventilated on 100% FiO2, and this acidemia, which is very, very significant. So what we're dealing here in light of this potential toxic ingestion of this substance called Iron Horse is methemoglobinemia. So basically what methemoglobinemia is a conversion of the iron that lives in your hemoglobin, which allows us to carry oxygen to all our tissues, is converted from Fe2 plus, which is ferrous, to Fe plus, which is called ferric. And a way to think about that is when your iron that is in your hemoglobin is in its ferrous form, the Fe2 plus, it is like an open hand that is able to grab hemoglobin's goal, which is to grab oxygen so it can attach and then carry it to the tissues and have normal hemostasis. When you have that ferric form, you could think of it as a closed fist that's unable to actually grab onto anything. So this patient has methemoglobinemia, presumably from this toxic ingestion of that substance that EMS reported he ingested, and he has still residual acidemia, hypoxia, and cyanosis. And this really dark blood that you remember was drawn when we initially were putting our lines in. So what we basically term that is chocolate blood. So it comes out looking like milk chocolate. And so what is the incidence of methemoglobinemia? Methemoglobinemia is not a particularly robust diagnosis that we see all the time. This is not your chest pain. This is not your pulmonary edema, pulmonary embolus, acute coronary syndrome. This is a toxicologic emergency that we're only seeing about maybe 100 times across the country in the emergency department. At least that's what's being reported. But when it is noted, of which we need to keep a high index of suspicion, you want to keep in mind that this has approximately up to 30% mortality. So if this goes unrecognized and not treated properly, your patients could have significant morbidity and mortality related to this. So what causes this? This is exposure to oxidizing agents, oxidizing chemicals. So examples of this are amyl nitrate, benzocaine, lidocaine, nitroglycerin, nitroprusside, things like that. And like I previously said, this converts your iron from one form to another form. This converts it from the ferrous, which accepts oxygen, to ferric, which makes it incapable of accepting oxygen and carrying it to the tissues. So how do we treat this? So you basically are working this patient up the way you would almost any other respiratory distress patient. So anyone who presents with dyspnea, tachypnea, cyanosis, and maybe plus or minus the acidemia that we noted. When these patients present to the emergency department, they get the standard monitoring that we're talking about. They get that pulse ox. Speaking of pulse ox, what you're going to notice a lot in this case, and as we did discuss in this case scenario, is that these patients will have pulse oximetries of about 85. And this has to do with the toxicological effects of the methemoglobin attached to the iron in the patient's hemoglobin, where the two wavelengths that are used to determine your SpO2 kind of get wacky, and it'll have this almost pathognomonic finding of it's always 85. So that's just something to keep in mind. These patients should be treated with removal of exposure to the toxin, which we've done. We're not letting him chug any more Iron Horse. And he is going to get supplemental oxygen. In this case, the patient was getting 100% FiO2 oxygen via endotracheal intubation. And then we are going to administer an antidote. The antidote should be administered for anyone who has a toxic level of over 30. So if they have a methemoglobin of over 30% from their ABG or VBG, you are going to definitely want to treat with the antidote, which I'm sure you're all dying to know what it is, and that would be methylene blue. So you might remember that from chemistry. I don't know, maybe you've seen this in the emergency department or the ICU before where they've had to treat with this. Methylene blue is a agent that actually, when infused intravenously, it will actually convert that iron ferric or the Fe3 plus back to Fe plus or ferrous and able to accept. And this will start to resolve the acidemia. The patient will improve with the level of their cyanosis. They'll begin to pick up, and you will notice that they will actually be doing much better than before. The patient that we actually discussed earlier, you can either dose 1 to 2 milligrams per kilogram. He got two IV rounds of this medication and had significant improvement in his clinical presentation within 30 minutes of receiving this medication. So one of the only things you have to keep an eye out with the administration of methylene blue, an interesting little factoid, is that if you go ahead and place the Foley in this patient, you may actually notice a change in the patient's urine from yellow to green. So that's an interesting thing to know that it's actually being used and metabolized in tox cases like this. So if you have any questions about this, please let me know, and I look forward to speaking to you guys soon. Take care. This is Emergency Life.